ฮัลโหลค่ะอาจารย์เริ่มเลยนะคะ
เริ่มได้เลยค่ะถ้าคุณครบแล้วค่ะ
ค่ะอาจารย์นันอนงค์บอกกำลังเดินมาค่ะค่ะก็เป็นภาษาอังกฤษนะคะค่ะก็ Good evening Good afternoon everyone my name is พันวศร I am second year resident today I'm going to present interesting case so let's start with the chief complaint. A 74-year-old Thai female presented with low back pain for one day. One day prior, the patient developed pain at lower back radiating to both calves with exacerbate up-arm movement. Peripheral numbness in the hands and feet remained unchanged. There were no accompanying symptoms such as fever, dysuria, urinary incontinence, or motor weakness. Bowel and bladder control remained intact. The patient denied any history of trauma, and the patient visited the outpatient clinic, and the doctor diagnosed muscle strain management at OPD. uh, the doctor gave Thermal and Pasil intravenous, and after re-evaluate pain, the pain was improved. So the doctor discharged and gave the patient prescribed home medication, Altoset and gabapentin. And the next day, the patient revisited to the outpatient clinic again with persistent back pain radiating to both thighs, with greater radiation to the left lower extremity than the right. There is no associated numbness or motor weakness. The pain is markedly aggravated by movement, resulting in significant limitation of mobility. Symptoms have not improved despite prior use of analgesic medication. And for the past history, th- her underlying disease is diabetes mellitus, hypertension, dyslipidemia, gout, hypothyroid, ASID on hemodialysis, and the current medication as shown above. For the physical examination, vital sign is unremarkable, and the positive finding is moderate tender at lower lumbar spine with no stepping, and motor power grade 5 or extremity, and diminished sensation due to chronic venous disease, both distal feet and state leg resting test negative, intact bar bladder control. So the problem list is low back pain with radiculopathy and underlying disease. So what is the differential diagnosis in this patient? Could anyone in the floor address this question?
So from the problem list, the patient female, 24 years old, come with lower back pain with radiculopathy. The first disease that I think for is spondylolisthesis because uh, it could come with lower back pain with radiculopathy and aggravate with the movement. And from the physical examination, have a motor power grade for decreased motor power at L2 and S1 with decreased pinprick sensation, and for the age group can be in the spondylolisthesis also. And the second one is spinal stenosis because it can come with low back pain also with radiculopathy, and she has tender at the spine, and the age group is can be spinal stenosis also, but uh it shouldn't accurate, but it will be maybe chronic intermittent pain which didn't match in this patient.
Okay, thank you, Non-Deal, for the answer. So the approach to back pain, uh, it- the category is will be in main three group: the primary back pathology, the systemic disease, and liver pain. In this patient, she didn't have any systemic symptom such as like fever or other abdominal pain. So the main category that the most likely diagnosis is in the group of primary back pathology, which is have like musculoligamentous injury, spondylosis, intervertebral disc herniation, anatomic abnormalities such as scoliosis, spondylolisthesis, spinal stenosis, and compression fracture. And in this patient, the most likely diagnosis as non-dual answer is spondylolisthesis because the age group is more common in okay. And the symptoms she present with low back pain with radiculopathy and aggravated with movement. And the physical examination state like lacting test negative, but the physical examination didn't mention the stepping in this patient. And the second disease that prefer is spinal stenosis because the patient have low back pain with radiculopathy and tender at the spine. But usually the spinal stenosis is must have like chronic intermittent pain and improve with flexion. And the third disease is herniated nuclear purposes because the patient presented with low back pain and with radiculopathy, but this disease is common in age group 20 to 35 years, and in this patient have no history of heavy lifting and the state like lasting test is negative. And other disease that can be in this patient is muscle strain because patient present with low back pain, but uh, usually muscle strain didn't have like radiculopathy, and the physical examination might tender at paravertebral area. So, what is the further investigation in this patient?
Film X-ray LS spine.
Okay. So, the doctor at our patient sent the film LS spy, and could anyone read the film?
It's not seen fracture. It's seen L5 is backward to L4.
Okay, in this film, the lateral view of LS spy, you will see the L4 is slipped when compared to L5 spy. So this is the spondylolisthesis. Uh, the same AP and lateral. So the diagnosis in this patient is L4, L5 spondylolisthesis, and the management at orthopedic OPD, they give ketorolac and dexamethasone and advise the patient for the weight reduction and core body exercise and follow up 2 weeks and advise left exercise. So the topic today is spondylolisthesis. For first, let's start with the definition between spondylolysis and spondylolisthesis. Spondylolysis is the defect of pars interarticularis in this picture, and spondylolisthesis is the forward slippage of vertebral body relative to the one below, like in the patient. In this picture, in the picture B, show the lateral view of spine, film, and in the picture A, show the oblique view. In the oblique view, you will see like the Scotty dog in this. And in the arrow, show the artistic rendition of the Scotty dog. So it means it have like high intercularis fracture. Okay. And for the etiology, they have the view classification to classify the etiology. Type 1 is congenital. It's like the dysplasia of neural arch of Sacrum. And type 2 is ischemic type. It's common in pediatric. And type 3 is the degenerative type, which common in older adults. And type 4 is traumatic, and type 5 is pathology. For the incidence of spondylolisthesis is seen in 4 to 6% of population, and spondylolisthesis, the most anatomical is L5 to S1 occur 82%, and L4, L5 occur 11%. For the clinical history, the patient will present with low back pain, typically intermittent, and may worsen with friction and extension. And other uh, clinical history the patient will come with radicular pain, which characterized by sharp or shooting sensation radiating to the lower extremity, like in this patient, and improve in specific position such as lying, which reduce instability and decompress neural structure. And other associated symptoms that may are seen in the patient could be buttock pain, leg numbness or weakness, and difficult ambulating, and in that case, bowel or bladder dysfunction can be occur. And for the physical examination, the physical examination should include inspection for step of deformity or exaggerated lumbar lordosis, palpation of for tenderness, and evaluation of lumbar range of motion, particularly noting pain during extension. And neurological assessment includes testing motor stage, sensory function, and reflex, which may reveal deficits consistent with nerve fluid involvement. Provocative maneuvers such as a stroke test or hyperextension may reproduce the pain and suggest mechanical instability. On this test, the stroke test, the patient stands on a leg with the other leg fixed at the knee and then extend the lumbar spine. If the lumbar pain is exacerbated, then the test is positive. And other physical examination also include gait examination and skin for concurrent pathology such as hip or sacral iliac joint dysfunction. And for the investigation, the first investigation, send like the radiograph, like common views obtain AP lateral, oblique, and friction extension. The finding of like the AP view is deformity in colonal pain, and lateral view you will see spondylolisthesis and pars defect. And for the friction extension views, as to assess the instability of spine. The instability defined as 4 mm of translation or 10%, 10 degree of angulation of motion compared to adjacent motion segment. And the MRI will send if the patient have the neurological deficit. The view that are the best study to evaluate the phenomenal stenosis and compression of neural element is T2 parasagittal view. And for the management of this disease, the first one should be the conservative management, which is an include the NSAID, physical therapy like core stability, lumbar flexibility, and hamstring stretching, which aim to reduce mechanical strain and improve posture. Bracing may be employed for symptomatic instability in pediatric patients, and other is activity modification. And in case if patient not improve with the conservative treatment, epidural steroid injection could be applied to relieve the pain. And for the operative management, the indication is persistent pain unresponsive to conservative measure and neurological deficit and progressive deformity. For the operation for spondylolisthesis is decompression with instrumented fusion. Okay.
Okay, uh, for me in the OPD setting, I think the key point is patient presenting with back pain, you need to be differentiate between mechanical back pain or inflammatory back pain. Could you tell me how to differentiate mechanical back pain and inflammatory back pain?
Ask the patient the left side. If the patient have like fever, is prefer inflammatory back pain more, and the activity that patient done. If the patient like have the history of heavy lifting or exercise, maybe you prefer the mechanical back pain and the physical examination.
That's okay. And I want to wrap up for you. Mechanical back pain is mostly worse with movement and activities and improve with rest. Others, in the other hand, inflammatory back pain, no improvement with rest and may have morning stiffness. Okay, for in this case, mechanical back pain is suspected. And after you suspected mechanical back pain, the next key point is there are any reflex signs to assess, okay? Such as neurological compromise or caudal equina syndrome. If the reflex signs are present, the patient should be referred to specialist, okay? This is the key for OPD setting. The first one, inflammatory back pain or mechanical back pain. The second one is need to refer to specialist or not, or there are any reflex signs. That's all.
Okay. Thank you for Ajahn Sirima for wrap up this.
In older patient, please look for metastasis. You have to look for clinical for malignancy. And if you are general practice, please advise this patient.
ได้
Advise how
ก็ไม่ถึงว่าให้ advice ก็ advise the symptom that patient should come back to hospital like weakness, motor weakness or feel more numbness, or the patient cannot the patient have bowel bladder dysfunction. Exercise, and for the exercise, advise the exercise to improve the core muscle of vertebral. มีใครมีอะไรถามอีกไหมคะมีใครเพิ่มเติมอะไรอีกไหมคะ
Don't forget to advise all patients for screening for post-menopausal osteoporosis. Okay, thank you.
Thank you. โอเคค่ะงั้นขอบคุณอาจารย์ทุกท่านนะคะ แล้วก็เพื่อนๆน้องๆในฟอนะคะ ขอปิดการนำเสนอครั้งนี้นะคะ ขอบคุณค่ะ
นี่ค่ะ